Boa tarde a todos. A gente está muito feliz de começar a segunda sessão de treinamento, né, desse nosso estudo em colaboração entre Brasil e Estados Unidos, com apoio fundamental do time da Universidade de Stanford, com a doutora Krisa e a doutora Valerie Chock. E hoje a gente vai falar sobre um tema que é realmente muito importante, e quando você fala em níveis globais, existe uma carência muito grande do treinamento do exame neurológico, né? E especificamente a gente vai falar do score de Sarnat Modificado. Então a apresentação de hoje vai ser muito baseada nisso. A gente vai ter três partes, uma parte onde a Krisa vai apresentar, né, todo o racional de como faz o exame. A gente vai ter 2 casos clínicos e, na sequência, a gente vai falar alguns dados que a gente tem de estudos prévios aqui no Brasil e, naturalmente, a gente pode abrir para questões. A gente sugere, a gente pede que especialmente durante os casos e após, que vocês fiquem à vontade, podem abrir o microfone, podem mandar perguntas pelo chat, fiquem verdadeiramente à vontade para participar. Bom, muito obrigado a todo mundo que conectou. A gente já está com bastante gente na sala. Estamos bastante animados. Danny, Krisa, just one last thing. Could you just record the
Oh, yeah.
Oh, it's recording
I think
already.
it's already recording.
Okay.
Yeah.
Okay.
But yeah.
Yeah,
I
no,
think
it's already recorded.
Yeah.
So, Danny.
Ok.
Perfect.
Bom, pessoal, acho que a maioria já me conhece, então a gente está realmente muito feliz em estar dando continuidade aí no segundo treinamento. Hoje a gente vai ter, então, a Krisa, a doutora Bianca e a doutora Juliana, que estão da PBSF também. E eu vou apresentar a vocês também a Laura. Alguns de vocês já conhecem, a Laura Tafner, trabalha com a gente na PBSF e além de mim, da Dani, residente, da Jéssica, residente, a Laura vai estar acompanhando também os nossos treinamentos e as coletas de dados. Então, se vocês tiverem qualquer dúvida, a Laura também será um contato aí para ajudar a gente nesse estudo, tá bom? Bem-vinda, Lau.
Obrigada.
Eu vou compartilhar com vocês rapidamente, só para vocês terem uma ideia de como ficou o preenchimento daquele questionário que a gente enviou para vocês. Então, a gente teve... Vocês estão vendo minha tela?
Estamos.
Então, a gente teve 60 respostas. No dia do treinamento, a gente teve um máximo de 82 pessoas conectadas ao mesmo tempo. A gente encaminhou para todos os hospitais o vídeo para que pudessem assistir posteriormente. E a gente mandou o link, né, com questionário para que as pessoas respondessem, justamente para que a gente pudesse quantificar quantos profissionais de cada hospital participaram, né, do treinamento. Então, a gente teve 60 respostas. Então, pensando em profissionais, a gente teve 34, então, né, mais de 50% são neonatologistas, outra grande parte enfermeiros, mas a gente teve também residentes, né, uma parte de residentes, a gente teve técnicos de enfermagem participando, fisioterapeutas, residentes de pediatria, residentes de obstetrícia, de neo e pediatras. Então, a gente teve uma grande variedade aí, mas predominando aí os neonatologistas. Quando a gente pensa, olhando aqui para os hospitais, então, para a gente ver quais os hospitais que mais responderam, né, que tiveram mais profissionais participando do questionário, então, a gente teve 15 pessoas do Hospital Jorge Rosman, em Itanhaém, 7 pessoas responderam do Hospital Geral de Guarulhos, 6 da Santa Casa de Santos, 6 pessoas de Pirajussara, 8 pessoas dos Estivadores. Então, a gente consegue ver, né, uma da Santa Casa de São Paulo, Irmanduce, 2 pessoas, Nicolau Urbano de Campos, 6 pessoas, Santa Casa do Pará, 3, Cachoeirinha, 2, Amparo, 7, e uma pessoa do Nicolau Urbano Macaé. Então, a gente tem aqui as outras perguntas, né, que todas as perguntas eram relacionadas ao tema da aula, mas as perguntas não são obrigatórias, né? Não é, o questionário ele é totalmente anônimo, a ideia não é ver quem é a pessoa, se sabe ou se não sabe o que está respondendo. Na verdade, é para, né, ajudar na fixação de conhecimento, essas questões, e essas duas primeiras que são as mais importantes para a gente conseguir quantificar quais profissionais foram treinados e quantos de cada unidade. Tá? A gente trouxe esses dados só para mostrar para vocês, para que vocês estimulem cada vez mais as equipes, né? O primeiro treinamento já teve um número bom de pessoas treinadas, mas a gente sabe que as equipes são muito maiores que isso, então, para que a gente consiga estimular em todos os centros, né, mês a mês. E aí, aqui para vocês, eu só vou abrir rapidinho, só para você, quem tinha perguntado, eu estou mandando sempre no grupo, mas para vocês verem as próximas datas, que acho que é bom também para as pessoas conseguirem se programar. Então, a gente tem hoje dia 10 e o próximo, nesse mês, é dia 24. Então, é sempre na quinta-feira, às 16 horas. Então, se vocês puderem, né, ter esse engajamento aí, tentar estimular a equipe a participar do treinamento, tá bom? E obrigada.
Obrigado, Dani. So, Krisa, I think we are ready to start. If you want to share your screen, and you have the word. Thank you so much for being with us again.
Okay. Let's see. I need to bring this down, slideshow. Oh, that's up there. Good afternoon. It's a pleasure to be back here again to speak. And you can see today we're trying out what PowerPoint could do with voice translation. So you'll have to give us some ideas of how helpful this is. So I want to remind you again that the therapeutic window for hypothermia is about a 6-hour period between primary energy failure and secondary energy failure. And this is important as we begin to discuss the Sarnat exam and when we determine eligibility for cooling. Another thing to keep in mind is there's a huge spectrum of encephalopathy from babies that are normal all the way up to babies that are most severe. The babies that are most severely impacted are easy to recognize, and as well as those that are on the more severe side of moderate. But often once you get to the mild to moderate continuum, it can be more challenging. And this is something that we need to be aware of in performing the neurologic exam. So at Stanford, and for many of the trials done for therapeutic hypothermia, these were some of the screening criteria. The first one was greater than or equal to 36 weeks. And as I spoke about a few weeks ago, there were only 2 trials of the therapeutic hypothermia trials that were performed that enrolled babies at 35 weeks. So at Stanford and at some institutions within the US, we do not routinely cool babies at 35 weeks. I also mentioned last week that a randomized controlled trial has been done looking at cooling in babies 33 to 35 weeks. But we do not have the results yet. We also obviously look at babies less than 6 hours of age and babies that come into our nurseries with a diagnosis of acute perinatal asphyxia, neonatal depression, or metabolic acidosis. In some hospitals that aren't large hospitals, babies with HIE are very infrequent. We know that the incidence of neonatal encephalopathy is between 1 and 6 cases per 1,000 births. So in a hospital of about 3,000 births per year, they are not going to see very many babies. So nurses that are attending deliveries, pediatricians, and even neonatologists need to be reminded about some of the things that need to be looked for right in the delivery room. This is an algorithm that we developed in Northern California with a group of about 15 to 20 hospitals in the northern part of our state. And we came up with these screening criteria. And so this algorithm is meant to be placed on a warmer that's in the delivery room so that people would continue to be reminded of what potential things to look for. So the things we identified between 0 and 10 minutes, they should look for the APGAR being lesser than or equal to 6, a history of an acute perinatal event, continued need for positive pressure ventilation at 10 minutes or a need for chest compressions, cord blood gas with a pH less than 715 or a base deficit greater than -10. So then this reminds them to go on to request a cord blood gas, also get a postnatal blood gas at less than 1 hour of age, and then perform the Sarnat exam. And we have a summary of the exam on the flip side of this. And then they're instructed, if needed, to call a neonatologist at a cooling center in their area. And again, this is available at Cooling Toolkit at www.cpqcc.org. So I also showed you a couple of weeks ago this process, and these are the inclusion criteria we use for cooling at Stanford and are used fairly widely around the United States. Pathway A and pathway B are slightly different. Pathway A is for the babies with more severe acidosis. And after meeting those criteria, the babies proceed on directly to get the modified Sarnat exam, where pathway B is a little bit more complex. And here's another way of sort of showing the pathway, where you can see here pathway A, you go straight to the neuro exam, where with pathway B, when you have a more moderate degree of acidosis, you then need either an acute perinatal event, and with some of the perinatal events listed here, and then either an APGAR score at 10 minutes lesser than equal to 5, or the continued need for ventilation starting at birth and continuing on for 10 minutes. And then the baby would proceed to the Sarnat exam. We exclude these type of babies still. And now I'm going to go on to describe the Sarnat exam, the purpose of this talk. So as you probably know, there's 6 categories: level of consciousness, spontaneous activity, posture, tone, primitive reflexes, and autonomic nervous system. 2 of these categories have subcategories, and this tends to lead to some confusion. When they have subcategories, you use the highest score in that category, and we'll go through that. Each of the categories contributes 1 point, and to be eligible for therapeutic hypothermia, 3 of 6 categories have to be coded as either moderate or severe. If the baby has a seizure, then they are eligible for cooling without 3 categories being moderate or severe. So this is the diagram that appears in Sita Shankaran's original article in New England Journal from 2005. And as you can see, we only highlight the moderate and severe categories here. We've now gone on to sort of expand this modified Sarnat exam to include normal and mild, because at this point, a question is coming up of whether we should be cooling babies with mild HIE. So we have decided to make people more familiar with the breakdown into the four groups. And this is shown here on this slide. And I believe this is what data that you're going to be capturing as part of this collaboration. And here's the autonomic nervous system. As you can see on the far right-hand side of the screen, there is a place available for people to record the score in each category. So neurological exams after birth can be challenging because of the effects of the delivery, potential anesthesia, and analgesia. Examination findings may improve or get worse, and this depends on the severity and timing of the hypoxic ischemic event. Compensatory hemodynamic changes that may happen after resuscitation, and endogenous CNS protective mechanisms like tachypnea for acidosis. Babies that have respiratory distress are also a little bit more challenging to examine and to determine the modified Sarnat on. You often, and most often, find a mix of neurologic findings, that a baby will not have all moderate findings, all mild, or all severe, but they'll have a mixture. Points to consider to examine in 2 phases. You first want to observe and then do active manipulation. You definitely, though, do not want to score a baby who's completely asleep. The baby needs to be in an awake state. So that may mean that you need to rouse the baby first. But then you start with observation, the baby's activity, posture, heart rate, and respirations. And then you do the least noxious part of the exam first, things like tone, and the most noxious last, which is definitely looking at the pupils and determining pupillary response. While seizures make a baby eligible, the Sarnat exam needs to be done on babies that have seizures and then documented. When is the optimal time to perform the exam? This is something that was not discussed in the randomized controlled trials that were performed as part of the early trials. And I think one of the reasons was that most of these babies were outborn, so early exams were not possible, and babies needed to be transported into the cooling center. So often the exams were performed close to the end of the 6-hour period. And I think that this was true for when we were involved in Sita Shankaran's NICHD trial. Currently, in thinking about this, experts feel that the best time to perform the exam is at about an hour of life. And this was actually a question I asked a number of years ago to Sita Shankaran and Abbott Laptuk, who were some of the PIs for the first trial. And this has been something that has been agreed upon. And currently the trial that we've just concluded here, the HEAL trial for erythropoietin use in babies with HIE, they did not allow a neurologic exam before 1 hour of age. And to have this consistency across examiners, I think is important. So what we do is we usually examine potentially eligible babies hourly up until about 6 hours of age. What happens after that is dependent on whether your center has decided to use late hypothermia. So now going on to the different categories. First, we're going to discuss level of consciousness. You code 0 or normal if the infant, when awake, is alert and fixes on external stimuli, like a face at the bedside. Code 1 if the baby appears irritable, hyperalert with excess crying, alternating with sleeping. Code 2 if the baby is lethargic, has a delayed but complete response to stimuli. You first start with mild stimuli, then proceed to more noxious stimuli. Code 3 if the baby is stuporous or comatose, not arousable, and non-responsive to external stimuli. They may have a delayed but incomplete response to the stimuli. Remember that level of consciousness may be the deciding factor to assign HIE stage when you end up with 3 moderate and 3 severe findings. I'm going to now show you some videos that were performed at Stanford about 5 years ago to help with teaching the Sarnat exam. And later in the presentation, I'll give you the link to these so that you can have them and use them for reference.
This term newborn has a normal level of alertness. The eyes are open. And even though sleepy, the baby's eyes, again, open, looks at the examiner, maintains visual focus on the person standing next to the cot. This neonate has a moderately abnormal level of consciousness. The baby is lethargic. There is a response to stimulation when the examiner stimulates the baby, but no sustained alertness or eye opening.
The next category is spontaneous activity, and you code 0 if the infant has frequent spontaneous movements when awake. Code 1 for mild if the infant has increased and exaggerated movements and is jittery. Code 2 if the activity is decreased. Code 3 if there's no activity. If the baby is sedated, clinical judgment has to be used to decide whether the examination is reliable. Ideally, no sedation is given prior to the neurologic exam. And obviously, paralysis would preclude a meaningful exam.
This baby has normal spontaneous movements. There are small movements rather continuously, and you can observe nice fluid, continuous movements in all extremities, both at the big and at the little joints. This neonate has a jittery quality in spontaneous movements or spontaneous activity. There are movements present, but these consist of short, rapid movements in the extremities with a paucity of fluid, smooth movements. This neonate has severe encephalopathy in this video. As you can see, there's no spontaneous activity when the baby is at rest.
Now we're going to go on to posture. You want to observe the infant in the awake state. Code 0 or normal if the extremities are flexed in towards the trunk. Code 1 if there is mild distal or arm flexion with leg abduction or slight extension. Code 2 for moderate if there's strong distal flexion, complete extension, or frog leg position. Code 3 if decerebrate with or without stimulation. Decerebrate posturing is rare, but we did document it occasionally in the first whole body RCT. If the posture is abnormal but does not fit 2 or 3, please code as 2, so moderate. And again, here's just to remind you of decorticate versus decerebrate, which I always have to remember.
This newborn has normal posture. The limbs are held flexed inward at the arms and the legs. Even with manipulation, the baby brings the arms and the legs back flexed in towards the trunk. And the legs come back to the body. This neonate has mildly abnormal posture. At rest, the hips are abducted. However, the knees and elbows are flexed. When the baby's manipulated, he brings the knees back in towards the torso in flexion and slowly does return the arms back in towards flexion for a mildly abnormal posture. This neonate has mildly abnormal posture. At rest, the hips are abducted. This neonate has moderately abnormal posture. You see strong distal flexion in the closed fists and at the ankles, yet the legs themselves are extended. This neonate.
Okay, here's another also still picture of distal flexion of the wrists, and then if you look down here at the toes, you can also see it at the toes. Tone, response to passive movement, code 0 if tone is normal, code 1 for mild if tone is slightly increased, code 2 if the baby is hypotonic or floppy, either focally or generalized, code 3 if the baby is flaccid like a rag doll. So you evaluate the extremities, trunk, and neck tone and make a clinical judgment of tone based on these areas. If the responses differ, base the code on what is present in the lower extremities. If there is varying tone, code the predominant state.
Here we see normal tone with leg traction. The examiner lifts the leg up off the bed and the baby maintains good flexion at the knee, resisting. Here we see demonstrated mildly abnormal tone, slightly increased tone. The examiner demonstrates assessment of the popliteal angle by stabilizing the leg against the trunk and then extending the leg at the knee. And as you can see with movement at the knee, the popliteal angle just barely reaches 90 degrees. There's an abnormal increase in resistance there. This neonate has moderately abnormal tone as assessed by head lag. The examiner supports the head as it's lifted up off the cot, but visibly there's only minimal effort as the baby does not attempt to lift the head or support the head as it's lifted. This neonate has severely abnormal tone. As the examiner assesses tone, she raises the arm up off the bed and there is no resistance. You can see that the arm remains straight. There's no bend at the elbow. Even as the arm's lifted up off the bed, the shoulder comes off the bed and there's still no resistance in the arm. It remains flaccid.
So now we're going to do primitive reflexes, suck and moro. For suck, code 0 if the infant has a strong coordinated suck, 1 for mild if the suck is uncoordinated, 2 if the suck is weak, unsustained, or infant bites. Code 3 if the suck is absent.
This newborn demonstrates a normal suck. The baby takes the pacifier immediately and has a nice, strong, sustained, rhythmic suck. This newborn has an abnormal suck, even with stimulation. There's only a few sucking movements at a time. There's not a sustained, strong suck as would be expected for a term neonate. This is abnormal for age. Here, we demonstrate an impaired suck reflex. As the finger's placed into the neonate's mouth, there's no sucking activity, even with repeated stimulation.
Now for moro, code 0 if, or for normal, if moro is complete with full abduction, then smooth adduction. Code 1 for mild if the moro is exaggerated. Code 2 if the moro is incomplete with partial abduction at the shoulder and extension of the arms. Code 3 if the moro is absent. If the baby has a fracture of the clavicle or brachial injury, evaluate only the opposite extremity. The moro has to be done gently, raising and lowering the head when the baby's intubated with someone protecting the airway.
Here we'll see a normal moro reflex. The baby's startled, both arms go out in extension and then immediately come back in flexion.
Now we're going to speak about autonomic nervous system, pupils, heart rate, and respiration. For pupils, code 0 if normal in size and reactive to light. Code 1 if dilated but reacting to light. Code 2 if constricted but reactive. Code 3 if deviated, pupils are dilated or non-reactive to light. If asymmetric, code 3. Pupils are difficult to assess in the newborn with edema of the eyelids. You will need to gently separate the eyelids while a second person shines the light. Heart rate, code 0 if the heart rate is in the normal range. Code 1 if the baby is tachycardic, usually greater than 160. Code 2 if bradycardic, less than 100, with only occasional increases to above 120. Code 3 if the heart rate is not constant and varies widely between 100, less than 100 and greater than 120. The heart rate should be evaluated based on a documented rate over the previous minutes to hours. Do not code heart rate if the cooling has been started. Respirations, code 0 if breathing is normal. Code 1 if it is irregular or tachypnic. Code 2, if there's periodic breathing present. Code 3, if the baby is apneic or is on a ventilator. An intubated infant with spontaneous breaths would be coded as 3, as it cannot be ascertained if the spontaneous breath can sustain respiration without ventilator support. So listed here with this link is the link to the video clips I showed. And so these are available for educational purposes on this website here. And I encourage you to use them and to share them with anyone who wants to learn more about the Sarnat exam. So again, as I mentioned, we provide in our electronic medical record a dot phrase that inserts this into the electronic record and allows people to score the baby and document it within the medical record. And again, we do this on an hourly basis until we determine a baby is eligible for cooling. And again, this requires, eligibility for cooling requires 3 of the 6 categories to be scored as either moderate or severe. And then we document, we sort of count the various categories as shown here. And again, if the baby has 2 or fewer, you then would look for seizures, and the baby then would be moderate if with seizures were present, even though you don't have 3 categories being abnormal, being moderate or severe. If you do have 3 or more, you review the number of moderate and severe categories. And again, whichever category predominates. In the case where moderate and severe numbers are equal, then you'd look at what the level of consciousness, if it was moderate or severe. So important pointers. If following a resuscitation, the Sarnat exam shows evidence of moderate or severe encephalopathy, the newborn should be cooled as long as there's no exclusions and the other laboratory and historical criteria met. A lot of babies improve over time. And again, if an exam at 1 hour or later is abnormal, even though it's better at 2 hours or at 3 hours, that does not negate the overall risk of HIE and adverse neurodevelopmental outcome. Several hospitals in the US were doing what they called early escape from hypothermia. But again, this in the cases that have been reported in the literature, this often did not end well, that the babies then were later found to have neurologic injury that could have potentially been treated with therapeutic hypothermia. So we warn against or dissuade people from doing this. So newborns with laboratory or historical data making them potentially eligible, but who have a normal initial Sarnat exam should be examined hourly for changes in the Sarnat exam. And having done this for the last 20 years, there's been a number of babies that my research coordinators are telling me that I need to come in and examine, and they said the baby really looks pretty normal, but then we come in an hour later and the exam has changed and the baby is now eligible for cooling. So I encourage you to continue to examine these babies regularly. The last part that I'm going to talk about is how to teach the modified Sarnat exam. And what we've done here at Stanford and within the Neonatal Research Network is we designate 1 or 2 individuals as the gold standard examiners. And the way we became gold standard examiners was listening to a presentation like this, and then going out and practicing. So then we have the gold standard examiner examine the baby alone, and then ask other providers to come to examine the baby independently within a 30-minute period. And then you have a scoring sheet for the Sarnat exam that everyone fills out. And then you review the exams and see how much agreement between the gold standard examiner and the other people that examine the baby. And I think this kind of interaction is going to improve everyone's ability to have good reliability and inter-rater reliability on their Sarnat exams. So I'm going to show you here, and again, this is only part of this exam, and we're currently doing a mild HIE trial. And we've realized that determining if mild HIE is present is even more difficult because it is subtle and often subjective. But we feel that videoing some of these exams may be important teaching tools. So I'm going to show you this. And again, this is a baby that was enrolled in our mild HIE trial. And this is just about half of the exam. But I think it actually becomes a nice teaching tool where you can discuss what you see.
So, pupils. They do dilate. Pretty. A measuring tape, do we? One. The size of those pupils, but here, let's see. Give me a sec. Okay. Let's do the one. So much in the sex department. Oh, there's another one.
Okay, I think you could see there, though, this is a baby who definitely did not have a strong sustained suck. It was weak and unsustained, so it was a moderate finding, and the pupils were dilated. But again, I think this may be a good way to sort of increase education by videoing some of these exams and having people watch them and then score them even based on the video. I think one of the more difficult things to tell from a video is tone. As shown in Courtney Westhoff's video, they look at sort of popliteal angle and other things that make it visually a little bit more easy to interpret tone. So at this point, I'm going to pass off the two cases that I've prepared on to Juliana and Bianca to talk you through. And I'll continue to advance the slides. Or I'm sorry, do we want to actually, Gabriel, you're going to take over at this point, and so you can convert the language. Yeah.
Yeah, thank you, Krisa. Just a sec, I will share my screen.
Krisa, just curiosity, this baby that you recorded, he was at the end mild HIE?
Yes.
Yes, okay. We were discussing here, we would probably classify him as moderate, maybe.
Really?
So.
Well, we didn't go through the full exam, so yeah.
We totally agree about video.
He had you're right, for suck, he was moderate, but based on the other aspects of the exam, he fell into mild.
Okay.
Because he didn't have, 3 moderates.
Let me just 1 sec. I'm trying to share the screen. Some permission is not allowing me, but there you go. I think this is the one, right?
Yes.
There you go. Can you see my screen, Krisa?
Yes.
Right now?
Yes.
Yeah. So there we go.
That's okay. So as we previously talked with Krisa, we're going to do the cases in Portuguese, so we'll make it easier for everyone. So I'm going to start now, Krisa. Então, o primeiro caso de história obstétrica havia um prolapso de cordão e esse bebê evoluiu com desaceleração tardia por 5 minutos, seguido de indicação de cesárea de urgência. Teve um Apgar de 4, 6 e 7. A gasometria de cordão era normal, mas a gasometria colhida com 30 minutos de vida tinha um pH de 7,3 com um déficit de base de -10. Esse bebê foi entubado dentro da sala de parto e permaneceu entubado dentro da UTI neonatal até 30 minutos de vida. E aí a gente pergunta, né, se esse bebê preenche tanto a parte de história clínica quanto laboratorial para hipotermia terapêutica. Não sei se alguém quer falar, discutir.
Nesse ponto da discussão, a gente gostaria de abrir realmente, seja pelo chat, seja se alguém quiser abrir o microfone, se alguém quiser falar, é mais do que bem-vindo. A ideia realmente é treinar e não tem problema nenhum se acertar errado, a gente realmente não está olhando para isso. O importante é a participação. Alguém gostaria de pensar se esse bebê preenche critérios?
Bom, eu vou dar sequência, então o que chama atenção nesse caso são essas desacelerações tardias por 5 minutos e o fato desse recém-nascido permanecer entubado até os 30 minutos de vida. Foi dada sequência para o exame de Sarnat, né? Então, só retomando aqui, né, desses fatos que a gente ressaltou. Então, se você for seguir o fluxograma, né, um bebê maior que 36 semanas, com mais de 1,8 kg, apesar da gasometria de cordão ser normal, a de 30 minutos de vida tinha esse déficit de base entre menos 10 e menos 15,9, e ele tinha um evento agudo perinatal, que era o prolapso de cordão, além da necessidade de ventilação aí por 30 minutos de vida, ou seja, preenchendo aí maior que 10 minutos. Então, sim, respondendo, a gente vai seguir para a avaliação do score clínico neurológico desse paciente. E aí, nesse score, esse paciente pontuou no nível de consciência como letárgico, então no moderado, de atividade espontânea normal, então pontuando no leve, a postura com predominantemente flexão, pontuando no normal, o tônus em hipotonia, pontuando no moderado. Quando foram avaliados os reflexos primitivos, a sucção estava adequada, o humor completo, e quanto ao sistema nervoso autonômico, as pupilas estavam normais e a frequência cardíaca dentro do adequado também, e a respiração, na verdade, como estava entubado, foi considerado no grave. E aí aqui a gente tem, então, duas categorias pontuando no normal, a gente tem uma no leve, duas no moderado e uma no grave, né? Então, totalizando aí, quando a gente avalia tudo, numa encefalopatia moderada. Se alguém tiver dúvida e quiser mandar, senão a gente dá sequência para o próximo.
Se alguém tiver dúvida, pode abrir o microfone ou pode mandar no chat também, não tem problema algum. Deixa eu ver se aqui tem alguma mensagem no chat.
Então, dando sequência para o segundo caso, de história obstétrica, foi um parto normal, com Apgar de 6 e 6. Não tinha gasometria de cordão, mas a gasometria coletada do recém-nascido com 50 minutos de vida apresentava um pH de 7,02 com um déficit de base de menos 20. Esse paciente não foi entubado. E aí, de novo, a nossa pergunta se a história e o exame laboratorial corroboram para prosseguir com o exame clínico. E aí, de novo, o que chama atenção, né? No fluxograma, a gente tem aqui o déficit de base de menos 20, então ele vai para aquele primeiro caminho, né, com o pH menor que 7 ou o déficit de base menor ou igual a 16, então ele já vai direto, independente de história de parto ou qualquer dependência ou não de ventilação, ele já preenche critério direto para avaliação clínica.
Fatores adicionais.
Isso. E aí, nesse caso, o Sarnat pontuou em letárgico, de novo, né, esse paciente no moderado, então, atividade espontânea não tinha nenhuma, então pontuando no grave, a postura com flexão distal, pontuando no moderado também, o tônus flácido, pontuando mais uma vez no grave, dos reflexos primitivos, ele na sucção, ao invés de sugar, mordia, o moro ausente, e no sistema nervoso autonômico as pupilas estavam normais, apresentando bradicardia e com respiração regular. Então aqui a gente totaliza 1, 2, 3 no moderado, né? Então preenchendo aí o nível de consciência, a postura e o sistema nervoso autonômico, né? Lembrando que dos 3 a gente pontua uma vez só, então para o sistema nervoso autonômico pela bradicardia, e no severo, no grave, a gente tem 3 também. Então nesse caso, a gente tem um empate entre moderado e grave, e aí como a Krisa brilhantemente apresentou para a gente, o que vai desempatar é o nível de consciência. Como ele pontuou em letárgico, né, que seria o moderado, a classificação desse Sarnat é moderada. So, Krisa, I'll give it back to you, to your picture.
Okay, this is just a picture that makes me think of all the collaborations over the years between our group at Stanford and the Brazil sites. And it's been a pleasure, both Valerie and I and many others, Kathy, Sonia, Gabriel Altif from Canada showing the pictures, have had the opportunity to visit Brazil. And there are some pictures here of Gabriel up at UCSF when we went to the Cooling Summit, shown there. And so the 2 pictures we have in masks, both in Brazil and in US, it's Valerie, myself, and Carolyn, one of our fellows. And we're hoping that soon that we can be without masks and get together in various locations to talk more about HIE cooling and neurodiagnostic monitoring of babies. We look forward to stopping this isolation, hopefully in the near future, and being able to get together.
Yeah, Krisa and Bianca, thank you so much. This was an amazing presentation. We definitely agree that, you know, we have learned so much with you and we're still learning. And this study is a beautiful example on how international collaboration can improve the quality of care on a large scale. So I think we'll move on to the last part of this presentation, where Juliana, Letra will talk. Just give me just a sec so I can share the screen. And I truly encourage everyone to visit US and visit Stanford one day, maybe. Yeah. It's really a fantastic experience.
We will plan our next course, hopefully for sometime in 2022, once we see that things are opening up safely around the world.
Yeah. Yes. Look forward to it.
Boa tarde, a gente vai falar um pouquinho sobre a nossa experiência, né? Eu inicio falando um pouquinho do Sarnat e do que a gente tem de dificuldade, né? E o que a gente tem de dificuldade para poder realizar o exame, né? E depois a gente vai mostrar para vocês a pesquisa que foi feita, né? Mostrando em todos os centros do Brasil, né? Na maioria a gente conseguiu pegar quase todos os estados. Sobre as dificuldades em fazer a hipotermia e também em caracterizar o Sarnat. Então, vamos começar. Então, o Sarnat é descrito em 1976, né? Foi um trabalho que foi feito com 21 recém-nascidos, né? Que tinham sofrido um evento hipóxico, né? Uma encefalopatia, né? E aí esses bebês foram avaliados. E aí, a partir desse estudo, com essas 21 crianças, foi feito um sistema de aplicação que é simples e é feito para avaliação neurológica e a formulação de prognóstico. Ela identifica neonatos com maior risco para o desenvolvimento neurológico anormal e mostra a natureza dinâmica da encefalopatia, então, o estado de comprometimento funcional de um cérebro que sofreu a injúria. Então, a gente usa isso na nossa prática clínica, a gente acaba usando o Sarnat para aplicação, né, da encefalopatia, para fazer o diagnóstico dessa encefalopatia e acabar indicando ou não o protocolo de hipotermia. Então, durante essas 6 horas, que é o tempo que a gente usa, a gente faz a avaliação das crianças para poder indicar ou não o protocolo de hipotermia. Por isso que é importante a gente lembrar que precisa ser feito esse exame durante as 6 primeiras horas, né? Independente do resultado, leve, moderado ou grave, se você já indicou ou não o protocolo de hipotermia, é muito importante para registro e até para a gente poder ver como que essa criança está evoluindo, continuar fazendo o exame durante as 6 primeiras horas. Então, essa escala de graduação para pontuar a gravidade da encefalopatia é com base em critérios clínicos objetivos. Ele é destinado, então, para encefalopatias não progressivas, as metabólicas, as infecciosas e a hipóxia isquêmica, que é o que a gente mais usa, né, para classificação e para indicação do protocolo de hipotermia. E essa escala é uma escala importante, porque é uma escala aplicável por qualquer médico e sem necessidade de equipamentos especiais, tá? Atualmente, ela ainda é uma ferramenta de fácil execução, reproduzível à beira-leito, usada para classificação da gravidade da encefalopatia, e ela independe da disponibilidade de neuroimagem ou de técnicas específicas, né? Então, a gente tem hoje uma grande quantidade de instrumentos que a gente usa para poder avaliar tanto a questão neurológica da criança quanto o prognóstico, né? Então, a gente tem a realização do score de Sarnat, a gente tem a ressonância, a gente tem o AEG e a gente tem o exame neurológico propriamente dito. O importante que a gente quer frisar aqui é que em alguns lugares a gente não tem, às vezes, o AEG e a gente não tem, às vezes, a ressonância. E o Sarnat vem como um instrumento importante para a gente fazer essa avaliação. Então, você não precisa da tecnologia, embora ela seja importante, ela ajude a gente a classificar a criança, né? Mas o Sarnat, por si só, ele é importantíssimo como um instrumento de avaliação, para poder indicar ou não o protocolo de hipotermia e para a gente ver como que essa criança está evoluindo. Então, a padronização do Sarnat, ela requer a preservação de critérios básicos e aplicáveis no que diz respeito ao exame a ser realizado, como tônus, sinais autonômicos, postura, nível de consciência, entre outros, e as definições claras dos sinais neurológicos alterados. Aqui,
a gente tem percebido isso dado quando a gente faz a porta do refeitório. A porta do refeitório bomba. Seja lá o que a gente fizer, a porta do refeitório vai bombar. Porque nós estamos passando ali.
E todo mundo passa ali, né? Todo mundo passa por ali.
Alexandra, você pode fechar seu microfone, por favor?
Cara, quando tem o coral, é um sucesso.
Verdade, é verdade.
Por quê? Porque vai no lugar onde eles estão.
Alexandra, ao microfone.
Obrigado.
então, aqui, o que a gente quer chamar a atenção é que o exame ele precisa ser feito, né? Quanto mais a gente faz o exame, quanto mais a gente aprende. Então, o Sarnat é um exame que é de fácil execução, só que a gente precisa aplicar esse exame, né? Como a Krisa mostrou durante a aula dela. Tá? Então, a gente chama atenção para isso. Para a gente poder padronizar, para a gente poder usar esse exame até para estudo, até para verificar essas crianças, a gente precisa que ele seja feito, tá? Então, a importância do score. A avaliação clínica da gravidade da encefalopatia é útil para a identificação precoce de neonatos em risco, que podem se beneficiar de terapias neuroprotetoras. Então, como eu disse anteriormente, às vezes você não tem o AEG, às vezes você não tem uma ressonância, mas você tem um score de Sarnat para poder classificar essas crianças. O score de Sarnat modificado, dentro das 6 primeiras horas após o nascimento, é útil para prever resultados adversos posteriores após a encefalopatia neonatal. E para identificar os bebês com encefalopatia moderada e grave que requerem um tratamento com hipotermia. Então, é aí a importância da realização adequada desse exame. E aí a importância também do Sarnat na encefalopatia leve. Os estudos atuais, eles sugerem que alguns bebês com acidose perinatal e encefalopatia neonatal leve, diagnosticado com menos de 6 horas de vida, apresentam anormalidades neurológicas na alta da unidade da terapia intensiva, achados cerebrais de lesão hipóxia isquêmica na ressonância e altas taxas de incapacidade aos 5 anos de idade. E aqui está a nossa atenção, a importância da atenção a esse exame bem realizado, porque a classificação clínica da encefalopatia pode mudar o tratamento e o prognóstico dessas crianças. E aí, analisando, né, toda a nossa experiência, a gente vê que a gente precisa de uma necessidade de treinamento da equipe para poder fazer, o exame, a importância da realização do exame durante as 6 primeiras horas de vida, independente se você já classificou essa criança em moderado ou grave, ou normal, sem nenhuma alteração, você adequar o ambiente onde esse exame vai ser realizado. Então, às vezes, presença de coxins, de aparelhos e dispositivos que podem atrapalhar a realização, a documentação adequada do exame, até objetivando pesquisa, e a padronização desse exame neurológico na asfixia leve. Então, o exame precisa ser feito, mesmo que essa encefalopatia seja classificada como leve nas primeiras horas. E agora a gente vai mostrar para vocês a pesquisa que foi feita, né, que acabou se transformando num artigo, sobre a avaliação, né, de todos os centros aqui no Brasil sobre a hipotermia e a realização do exame de Sarnat, do score de Sarnat. Então, foi uma revisão sistemática que identificou que não há redução na mortalidade com a hipotermia terapêutica em países em desenvolvimento. Mas por que isso foi verificado? Porque a gente tem protocolos divergentes, a disponibilidade de equipamentos, muitas vezes não adequadas, falta de um suporte intensivo, profissionais inadequadamente treinados e a diferença nas comorbidades das populações, né? Então, apesar da gente já ter a certeza que a hipotermia terapêutica é usada e que ela muda o prognóstico da criança, se ela não for usada adequadamente, ela pode causar um resultado que não é o esperado. A pesquisa é realizada por meio de um questionário que continha informações do cuidado neonatal em asfixia perinatal, um diagnóstico de encefalopatia e manejo durante a hipotermia terapêutica. Incluiu perguntas sobre hipotermia na encefalopatia moderada e grave, número de casos tratados por ano, o treinamento específico em avaliação de encefalopatia e hipotermia terapêutica, o tempo de início da hipotermia, o método de resfriamento e monitoramento da temperatura e o acesso dos serviços o serviço de neurologia e a exames como o AEG, o EEG, a tomografia e a ressonância. E dados sobre encefalopatia leve também constavam nesse questionário. Então, aqui, só para dar um exemplo para você, né, das características dessa pesquisa, né, de quem respondeu, a maioria eram neonatologistas, então 63%, mas a gente também tinha pediatra, a gente também tinha enfermeiro, fisioterapeuta e também outros profissionais. Tá? Foi dividido, então, o tipo de hospital em que essas crianças estavam inseridas, então, um hospital público, um hospital privado, hospital universitário, a combinação do hospital público e do privado, tá? E as regiões do Brasil, Sudeste, Sul, Nordeste, Centro-Oeste e o Norte. O que a gente teve como resultado? 62% preferiam usar a hipotermia como tratamento para recém-nascido com história de asfixia, né, e encefalopatia. 38% que responderam que não usavam, tinha falta de equipamento adequado, falta de conhecimento ou de treinamento, e 94% não possuem centro de referência ou não é possível realizar a transferência dentro das primeiras 6 horas de vida. E aí, por conta disso, não conseguiam realizar a hipotermia. Então, os detalhes sobre o manejo da hipotermia foram fornecidos por 624 profissionais. Os números de hipotermia, então, 51% fazia de 1 a 5 hipotermias, né? E 21% de 6 a 10, maior do que 10% e 18% não sabiam dizer quantas vezes foi feita a hipotermia no seu serviço. Para diagnosticar essa encefalopatia, 58% usou o score de Sarnat, 8% usou um outro score, 22% não usou nenhum tipo de score para indicação da encefalopatia e 13% não sabe dizer o que foi usado ou o que não foi usado. Dos que usam o score, somente 20% receberam algum tipo de tratamento. E aqui a gente vê a necessidade da gente realizar esse treinamento para poder fazer a aplicação correta do score. Aqui, sobre os casos de encefalopatia leve, né? 62% não fizeram a hipotermia terapêutica nos casos da encefalopatia leve e 38% acabaram realizando a hipotermia. Passa o próximo slide que a gente deixa isso. As razões para não ser feita a hipotermia, né? Então, eles acham que a encefalopatia leve é associada com bons resultados no futuro, né? Falta de evidência para o suporte nessa população, para realizar nessa população, risco dos efeitos da hipotermia, né? Então, efeitos colaterais. Questão da intubação, né? Da ventilação mecânica e da sedação para essas crianças. E a gente teve 35% que não souberam responder. Aqui, da nossa experiência, o que a gente vê sobre a hipotermia, né? Sobre o resfriamento dessas crianças. 1,2% aconteceu nas primeiras 24 horas de vida, 34% nas primeiras 6 horas de vida, 48% logo após a admissão e 27% já em sala de parto, já na sala de parto. Então, aqui, possivelmente, o critério utilizado para indicar a hipotermia estava mais relacionado com a necessidade de reanimação lá em sala de parto do que a presença da encefalopatia diagnosticada realmente, o que pode levar à exposição desnecessária ao tratamento. Concluindo que a hipotermia vem sendo implementada, mas com uma heterogeneidade significativa desde a sua indicação ao seu manejo, e é necessário uma força-tarefa para prover educação e treinamento adequado em todo o Brasil, para que todo o estudo que a gente tem mostrando os benefícios da hipotermia sejam de fato entregues a esses bebês. E aí, só para falar para vocês aqui, a gente já está pensando num curso de capacitação em asfixia perinatal para a gente conseguir treinar as pessoas, né? Para a gente conseguir homogeneizar esse cuidado com o recém-nascido, tanto através mostrando como que é a hipotermia, né? E também como que é feito o Sarnat e os critérios para a gente poder fazer um tratamento adequado nessas crianças.
Acho que só para relembrar que a Dani pediu para a gente colocar mais uma vez, que ela trouxe no início, o nosso cronograma de treinamentos aí, com as próximas datas, para que todo mundo possa se programar.
So,
I think we have questions for Krisa.
Yeah, so Krisa, so I'd just like to say thank you to Juliana. This was fantastic, and it's very interesting to understand the data we have in our own setting.
Yes.
And now I think we are ready for questions. I'll just stop the sharing because I will now translate from English to Portuguese once again. So just a sec. There you go.
So I'm going to start with the first question. Krisa, besides Apgar score, isn't the main points to the decision to the clinical exam, people here in Brazil are very attached to this information. And we know by literature that we have some differences. Some literature we find the Apgar score of the 5th minute and sometimes the 10th minute, and the numbers vary too. So I'd like if you can talk about this a little bit, please.
Okay. Again, I think there's historical and biochemical sort of criteria. And I think the ones we tend to use probably the most, and it may be just due to practice differences, first of all, the cord blood gases or the baby's first gas in the first hour of life. And so that's the one we focus on first, along, with the APGAR scores. We have continued to use the algorithm used in the whole body hypothermia trial that Sita Shankaran performed, just because it did show efficacious results. And our American Academy of Pediatrics has reinforced that we should continue to use the eligibility criteria where the trial showed efficacy. Anytime you start deviating from what you've done that showed benefit, you potentially change the results. So we focused on, acidosis with the pH being less than 7 or base deficit greater than -16, then those babies go immediately to a neurologic exam. Whereas the babies with more milder degrees of acidosis have to go through that perinatal event, and then either the APGAR score being less than or equal to 5 at 10 minutes, or the baby needing continued resuscitation in the delivery room. Some people have modified the criteria and have a sort of a little bit looser one before they go to the neurologic exam. And, and that is being done in some hospitals in the United States. Again, because the trial was so large and performed, by a group we were involved with, we have stuck with the NICHD criteria. So yeah, I'm interested. So in Brazil, what is the most common criteria used for therapeutic hypothermia?
Yeah, Krisa, I think since we work and we give many workshops towards this, we are actually using most of times the NICHD criteria. So as I told you, we learn it with you and we spread the word here in Brazil as well. And not only the centers that we work, I'm pretty sure that most of centers in Brazil that are doing this per protocol are using the NICHD criteria.
Yeah. And again, any of these criteria, they're not absolutely perfect. And so I think in certain occasions, people will call me with a history of a baby, and despite the baby maybe not meeting some of the historical biochemical criteria, the baby has a very poor neurologic exam. So sometimes we do deviate and sort of liberalize our criteria, but again, after discussing it in detail.
Yeah.
Yeah, even in our clinical trials, we were involved in one of the phase 2 trial prior to the HEAL trial called the NIDO trial. Again, this is one for erythropoietin. One of the babies we enrolled, seemed perfectly to qualify for therapeutic hypothermia. But upon later, the baby remained hypotonic. The MRI showed a little bit of ventriculomegaly, not typical things for HIE. And eventually we discovered that the baby had congenital myotonic dystrophy. So I went back over the chart, and again, there may have been the myotonic dystrophy with a little bit of fetal distress on top of it. So sometimes we can't, figure out the entire picture at the time of birth.
It's really hard, right? It's not all.
No, it's not always straightforward. Yeah.
Yeah.
And I think when I saw that you had some questions, I think on your questionnaire about mild HIE and if people were cooling, it seemed to be in it. And again, I think in that group of babies, the Sarnat exam is even more challenging, determining when things go from mild to moderate. Yeah.
And entering this discussion, actually we have a few questions here, Krisa, that people are not sure how to classify the baby. If, for instance, the infant had a pH less than 7, then we go for the neurological exam. But if this baby only scores 2 points on mild HIE and the rest is normal, would you classify this as mild HIE or normal?
Well, if you said that there's 2 categories that scored as mild, then that would be mild HIE, definitely. Yeah. It's, you know, we've had some babies that have surprised us. We had a baby, a uterine rupture, you know, bad cord gases, but the neurologic exam was absolutely normal after birth. It scared me to death to not cool a baby that had had a, you know, uterine rupture, but the baby was fine. So again, sometimes sometimes you need to stick by the criteria, but again, you know, because we know that therapeutic hypothermia doesn't have a lot of adverse effects. I think this is something that has encouraged people sometimes when you've got a baby that is on the more severe side of mild HIE, you know, people have been inclined to cool some of those babies. But certainly we need to do a trial of therapeutic hypothermia or erythropoietin in mild HIE.
Yeah, because the next question, Krisa, is exactly the opposite. So imagine we have a baby that had a sentinel event, but the cord pH is normal, but it has moderate to severe encephalopathy. And the question would be, cool or not cool this baby?
Okay, so had a sentinel event, the cord gases were normal, and had encephalopathy. I would cool that baby. The reason why is you have to realize that cord blood gases usually represent the metabolic status before, you know, right before the baby's born. But if there's cord obstruction that can happen, you know, with shoulder dystocia, with other events where the baby obstructs the cord, at that point, once the obstruction has occurred, the cord gas does not represent the baby's metabolic situation. So there are certain circumstances when you've got a sentinel event and then you've got a baby's abnormal neurologic exam. I would definitely cool that baby.
Thank you, Chris. I think this is a very, very important discussion, and this is the kind of situation that we face many times inside the NICU.
Yeah, these babies don't read the textbook, right? They don't follow all the rules.
Exactly.
I think another one would be if she has any advices on how to access the cervical tonus. We have many people asking for us how would be the best way to clinical evaluate the tonus, because it's not always possible to do the ventral exam. So what do you think it's best?
Are you talking about assessing tone?
Yes, especially cervical tone.
Cervical, like you mean neck? Yeah.
Yes.
Yeah.
Yes.
Yeah. That, I think that's a hard thing to do in a baby who's encephalopathic. You probably saw that Courtney used like the popliteal angle because again, you're trying to differentiate, normal, mild, where it's slightly increased. So that popliteal angle would be a little bit less than 90. And then, moderate is hypotonia, either focal or moderate. So I don't focus on like, neck tone. That's not one of the things that I commonly do in a baby. So I'm looking usually more at the lower extremities and, again, a general assessment of tone. And so trying to differentiate where it's sort of more in the normal range, slightly increased. Again, that popliteal angle is going to help you. Or, moderate would be a baby that would either be focally or generally hypotonic. And that's fairly easy to determine. Then severe is a flaccid baby, and a flaccid baby is going to be obvious. Okay. So I think you have to think of the 4 different categories and determine where the baby is most accurately placed.
I think I have one. If we have a baby, doesn't need incubation, but he needs a CPAP, how can I classify this baby?
I'm okay. I missed some of that. Okay, the baby's on CPAP, and then I didn't.
Because normally we think about the intubation to classify the baby, but if the baby doesn't need the intubation, just the CPAP.
Right, CPAP.
Okay.
So CPAP does not count as mechanical ventilation unless there's a rate. So is that sort of the question you're asking? So if you're in the delivery room and you're just needing CPAP without manual breaths, then that does not count as continued respiratory support. And this is something that a lot of people often get wrong. So it's a sort of a very fine point of this. So again, so if it's just CPAP, it doesn't count as continued need for mechanical ventilation starting at birth and continuing for 10 minutes. So I hope I made that clear.
Yes.
So, Krisa, I think one of the main goals of this study is, of course, trying to promote homogeneity of care between different centers. And, of course, training is a really, really important topic for this. So my question to you would be, at Stanford, how you do or how often do you do the neurological training in your team? And as well, exactly how do you do this?
Yeah.
Is this workshops? What kind of tools you provide to the team?
Yeah. We usually, again, because we've been involved in so many trials, a lot of the trials have mandated what we have to do. And so most recently, we're involved in this mild HIE trial. So myself and Sonia, we prepared a presentation that got recorded. And so everyone in our division, all the neonatologists had to watch it. Previous to that, it was sort of an annual training, which is similar to what I've done today, going through the Sarnat exam, or through the eligibility, giving people cases and having people sort of debate the cases and say, well, why is this, moderate, not severe? And so again, much like what we're doing today, we for a lot of the trials, we had people that had to become trained examiners. So again, what we did in that case was what I sort of described. We did side-by-side exams. Like I would examine a baby, and then Valerie would come to the bedside, 10 minutes later with me not there, not watching, and we would each score them, and then we would compare the two exam scores and then discuss what we saw and why we differed if we did. And once we had two exams that had good agreement, then we said, okay, Valerie's also a certified examiner. So that was what we did for the trials, but now we've moved to just annual training for people.
Yeah, sounds great.
Yeah.
And here we have one question about certification, because people read very commonly that in the clinical trials, all the examiners were certified. Is this a common practice, or this is actually more for the clinical trials, Krisa?
This is for the clinical trials. And again, the process that I described was what we did, and that's how people became a certified neurological examiner. And so, but again, I think a practice like that is important, within a center. So when you're talking about a baby with moderate HIE, you're all talking about the same kind of an exam. Because I think we've, as neonatologists, we commonly examine babies, but this is a fairly structured exam with the 6 categories. And again, that's why we sort of broke it down, and when originally it was only the moderate and severe were described, but now we have normal, mild, moderate, and severe. And I think then, there are discrete descriptions of these babies. Again, there's still some subjectivity, again, as I think Juliana or Bianca said in the beginning, the baby with the video, the suck, they thought it was moderate. And I agree with that, but someone else might say, well, maybe that was just uncoordinated, not unsustained. But again, we tried to put in enough definitions and descriptors to make them separate as we could.
Fantastic. Thank you, Krisa. I think we have a question from Isadora. I think she will open the mic.
Hi, good afternoon. Can you hear me?
Yes.
Yes, Dr. Krisa, first, I would like to thank you for your lecture. And so about the other doctors that gave us lectures today. I have a question about one scenario, the delivery room. In some of my experiences, neonates that we predict that will be eligible for the hypothermia, like with acute events and low Apgar score. In some scenarios here in São Paulo, Brazil, I've seen we start maintaining these neonates slightly hypothermic since the delivery room. If we think they might be eligible for the hypothermia, we transport them to the NICU slightly hypothermic. I would like your opinion about it. Like if this, you think this is a good practice, if we should do this, or we should maintain him normothermic until the Sarnat exam. Thank you.
It's an excellent question that has been debated. And I guess I have the advantage of having spoken to Myra Wyckoff, who's one of the ILCOR and NRP heads, and also Abbott Laptuck. I think their feelings are it's best to resuscitate the baby in normothermia. And then once the baby's in the NICU and you've gotten a good exam around an hour, then to implement hypothermia. I've seen other hospitals a lot of times with babies that have, some difficulty in the delivery room. They start cooling, but then they're in the situation they have to rewarm the babies. And we know that hyperthermia is dangerous to the brain. And again, that was sort of a sub-analysis of the whole body hypothermia trial in an article published by Abbott Laptuck that showed that the higher brain temperatures, was associated with neurologic injury. So again, if you start cooling, too soon and then have to rewarm, I think that sets the stage for potential, brain hyperthermia. So we do not start cooling in the delivery room. We wait until a later time. Sometimes, because again, we think that maybe having the baby closer to normothermia may make the resuscitation easier. That's our approach.
Thank you, Dr. Krisa.
Thank you, Krisa. I think we have time for one last question and then for final comments. Krisa, what I would like to ask is, let's suppose you have a baby with a cord blood gas with pH less than 7, and the baby goes to the NICU, and now you assess for the neurological exam. And if the baby, if you agree that in the first hour the baby has mild HIE, how often will you repeat the neurological exam for this baby? And is this important, yes or no?
Very important, because again, these neurologic exams change. And again, after 20 years of doing this, I'm always surprised how much they can change in a short period of time. So we ask our neonatologists and our nurse practitioners to examine the babies hourly and to fill out one of those forms that gets into the electronic medical record to document what the neurologic exam was on an hourly basis, until we reach at least 6 hours. Since we do late hypothermia, then usually at some slightly greater interval, we will continue to examine the babies out to 24 hours. And again, some of these babies that are, I think, somewhat questionable how they're going to come out, we also put on AEG, because again, some of these babies are going to have like a subclinical seizure and then become eligible for hypothermia because of the seizure and not specifically for the neurologic exam.
Yeah. We usually, for babies with mild HIE that do not have the entry criteria for hypothermia, we usually do the EEG for 24 hours, just looking at the background activity and also for possible seizures.
Yes, good. That's a good practice.
I think we have time for final comments from your side, Krisa, and Bianca and Juliana as well. So, and from my part, I would like to thank, I think this was an amazing session once again. And I just would like to remind everyone that this is going to be recorded, and what we want all your team to look into this, because this is really, really interesting material for education.
Yeah. No, I think that this has been a lot of fun. I like teaching the Sarnat exam. It's really the basics. You know, we're neonatologists, we're used to examining babies, but having this very specific algorithm and sort of scoring system is something that's a little bit different. So I think this is, it's not a perfect exam, but, you know, I think we can get better at it. I think it'd be fun if we could all maybe collect some of these videos, watch them, and we could all score them and see how much we agree and debate what the findings were. I think that's potentially a very good teaching tool.
Completely agree. Bianca and Juliana, would you have any final comments?
No, I just want to, when I'm not sure if it was Isadora, just to point that Sarnat score can be modified if we access it while babies on hypothermia, right, Krisa? So we should do it with the baby in normothermia first, and because properly the hypothermia can manage to alterate some characteristics, right?
Yeah, obviously it'll affect the heart rate. Yeah, so.
Yeah.
Sometimes tones, I guess, tone too.
Yeah.
Okay, so yes, I think we will never finish having questions about Sarnat score, especially while we're experiencing day by day. Then we have the many doubts, but I couldn't agree more with the video tools. I think for learning, and especially having other people learning together and comparing the exams, it's amazing too.
Yeah, for us, you know, I think it gains the video exams. We're going to be looking at them and seeing if scoring agrees with someone who actually examines the baby. And our sort of desire to do this is related to the fact that still now a lot of our babies are born hours away from our hospital. And we have the Ticotherm, which is a small portable cooling device that we can send out with our transport team. So even a baby who's born like 4 hours away, we can get to the baby, start hypothermia, but then it's dependent then on the exam by a non-neonatologist. So we are, you know, hoping that the video exam can be something that we can look at here at Stanford and decide whether the baby meets the cooling criteria.
Interesting. That's like telemedicine.
Yes, telemedicine. Yeah. Tele-Sarnat.
Exactly. So again, I would just like to thank everyone, especially you, Krisa, and Valerie, Bianca, Juliana, and definitely all the attendees. I think this was a very nice session, and I truly looking forward for the next one. Thank you so much.
Yeah, thank you, Juliana and Bianca, for going through those cases. Yeah.
Thank you, Krisa. It was a pleasure.
Okay. So end the session. Thank you so much, everyone.
Okay. Bye-bye.
Bye-bye. Take care.